Hi, I am presenting a case of total laparoscopic hysterectomy for pelvic inflammatory disease. A 42-year-old multiparous who had history of two lower segment cesarean section done had repeated episodes of pelvic inflammatory disease with a severe dysmenorrhea and menorrhagia. Her ultrasonography showed that there is a right side tubo-ovarian mass. She was suffering from dysmenorrhea so much that she wanted a hysterectomy and complete removal of all the adnexal mass, as it was a case of tubo-ovarian mass which is likely have a generalized inflammation of the uterus fallopian tube on either side. There was a right tubo-ovarian mass which was stuck to the posterior surface of the uterus and the rectum on the right side. So we started the surgery by opening the peritoneum between the round ligament and infundibulopelvic ligament so that we can identify the ureter, and then we can divide the infundibulopelvic ligament on the right side. Bipolar shearer was used to enter into this place, which was showing very good hemostasis when the dissection was carried out. Now we are reaching nearly to the ureter, which was seen by confirmation by peristalsis. So that is the ureter we identified. Especially when a patient having a distorted anatomy, many a times ureter may be well away from the site of surgery, but it is a good point to identify the ureter in its course and keep it safe. So that is the only way to save the ureter during the surgery, especially cases like this where there is a dense adhesions are anticipated. So now we have identified the infundibulopelvic ligament, and we noted that ureter is seen well away from the surgical field. Now we try to peritonize infundibulopelvic ligament again before we coagulate it completely, so that chances of retraction of vessels after the division when it is incompletely coagulated is not there. So before dividing it, better to have a complete coagulation of the vessels, and then we can divide it. Here vessel sealing tube, that is bipolar shearer, is used to coagulate the vessel. Making a window between the ureter and the infundibulopelvic ligament is one more way to completely safeguard the ureter. We can see the edematous fallopian tube and the ovary is stuck to the uterus. We are finding difficult to dissect it away from the uterus. So since she was opting it for total hysterectomy, so we thought we'll start with the division of the infundibulopelvic ligament, then we'll get exposure to the other pedicles. So we can see that once it is divided, so that pedicle got retracted. So now we are continuing the dissection towards the ovarian ligament now. Dividing the ovarian ligament midway between the lateral pelvic wall and the uterus will give a better exposure of the broad ligament. Sometimes if the adnexa is well stuck, if you are not able to divide it along with the uterus, in such cases we can divide the adnexa separately. So later we can tackle the adnexa after the hysterectomy is completed. So this is not utrovesical fold of peritoneum. This is a adhesion between the uterus and the lateral pelvic wall. Below this we can see the utrovesical fold of peritoneum. As we are anticipating more adhesions between the bladder and the cervix due to the previous two surgeries, and also inflammation due to the infection, which further increases the fibrosis between these two structures, and identifying the planes becomes little more tough. But if we do a meticulous and slow dissection, it is possible to identify these avascular plane. Keeping the surgical field clear and dry is very important in these cases to get a exposure of the underlying structures. Small amount of bleeding will stay in this area and you will find little more difficult, but at times it is not possible all the time to have a clean and dry field. Sometimes it may be messy, it may be stained. So now we can see that even a sigmoid colon is adhered to the lateral pelvic wall more than the routine adhesions, and also the sigmoid colon is adhered to the left side of the adnexa. If you are having a good place between the important structures like intestine and lateral pelvic wall, then bipolar shear is the good device. But if there is a very dense adhesions, when we are dealing very close to these delicate structures, then we better to go for a harmonic device which has at a very less lateral spread and good amount of hemostasis with a very less smoke. So these are the major advantages of harmonic. Slowly we are separating the sigmoid colon adherent to the left side of the pelvic wall. Now we are going to the retroperitoneal area, and then we are dividing the round ligament on the left side to get access to the retroperitoneal area, so that even on the left side we are able to identify the ureter and find the place between the infundibulopelvic ligament and the ureter. So these are the loose cellular tissue that is present in the retroperitoneal area. So the first structures usually we come across is the external iliac vessels, external iliac artery and external iliac vein, and then further dissecting down, deep down, we will see the ureter in the medial fold, and further dissection down we will see the internal iliac artery. These are the routine structures that are seen in the retroperitoneal dissection. That is in the medial fold we are able to identify the ureter. Always better to confirm it by its peristalsis and longitudinally running blood vessels on the surface of the adventitia of the ureter. So that is the uterine artery where I am separating it from the ureter in the left hand, and that is the peristalsis which confirms that is the ureter. So identifying the ureter throughout its course is a very good way to prevent the injury to the. So we can see that fallopian tube and the ovary is stuck to sigmoid colon. It is all because of the dense fibrosis and vascular adhesions between the two structures. So now try to separate the sigmoid colon away from our surgical field and try to identify the infundibulopelvic ligament. So now we are exposing the mesosalpinx. While using bipolar shearer, we can see we are dealing only with the tip of the instrument, which gives a very good hemostatic effect with a sharp cut. So that is the infundibulopelvic ligament is identified, and we saw ureter is well away from our surgical field. Now we can divide the infundibulopelvic ligament after coagulating it completely. So that is a complete division of infundibulopelvic ligament. Now some part is adhered to the ovary. If we go very close to the intestine, better to change over to the harmonic scalpel. Which gives a better control over the dissection area. And a better clear cut division. So the major adnexal separation on either side is done. Now we have to separate the uretrovesical fold of peritoneum from the cervix and rectum from the posterior surface of the cervix. So both are adhered. So we can see the ureter is very close to the site of the surgery. Identifying it throughout its course. So now we are dealing it with the uretrovesical fold of peritoneum. It is divided midway between the adhered area and the free fold to get a plane between the cervix and the bladder. So here little patience is necessary to find a proper plane between the bladder and the cervix, so that inadvertently we do not injure the bladder. If it is injured, we can very well suture it, but most important is you should not fail to identify the injury to the bladder, which can lead to the fistula formation in the post-operative period, which is more difficult to treat than treating it in the intraoperative period. So in this case, we are going to the anterior dissection, where lateral dissection plane was not available. So we tried to identify the lateral dissection of the bladder, but in this case, plane was not available. So we thought we'll go for an anterior dissection, where we are getting a better plane of dissection. So this is a dense fibrous tissue which need to be divided, and then we can get exposure to the loose cellular tissue. It will be present between the bladder and the cervix. Then we can separate it well away from our surgical field. So this fibrous tissue is being divided of the previous cesarean section scar. So though we are seeing the proper plane between the bladder and the cervix, we are taking little more time in confirming it, dividing all the fibers, and then getting exposure to the utrovesical fold up peritoneum, means utrovesical space. So that is the loose cellular tissue we got between the bladder and the cervix. So if we do the dissection in this proper plane, definitely the amount of blood loss is very less. So there is a proper avascular plane between these two, which needs to be explored. Before dividing the uterine veins and uterine vessels. So now we are going to the uterine vessels on the left side. Still we can anticipate a adhesion of rectum to the posterior part of cervix, which need to be divided, which we are trying to tackle it once we divide the uterine vessels. Some part of the utrovesical fold of peritoneum is still remaining on the right side. So that's a completion of dissection we are doing, so that right side uterine vessels are tackled. So we are finding difficult to separate the right adnexa from the sigmoid column. So we are trying to divide the cornual pedicles before to reach uterine vessels. And then later, after doing completion of the hysterectomy, then we can go and excise the adnexa of the right side. There was a good amount of exposure was available on the left side, but on the right side adnex tubo mass is stuck to the, and it is inflamed. So when it is inflamed, you should be very careful in handling the bowel also. So care should be taken. We do not injure the bowel. So taken as, so we can see that sigmoid colon is adhered to the posterior surface of the uterus, and it is obliterating the pouch of Douglas. In inflamed patients, so a small amount of injury will lead to more damage to the intestines. So should be very careful and keep it well away from the intestines and the bladder. So whenever we go close to the intestines, we take the harmonic scalpel. So that's what we are doing it here. So now we try to divide the left side transcervical ligament. So posteriorly also we have got enough space to divide the posterior part of the vagina. So now completion of the division of the vagina on the left side. Using unipolar. As the dissection was complete, so we can very well use the unipolar energy also. So we can see the right side of adnexa is still stuck to the sigmoid colon. So it is still attached to the sigmoid colon due to its adhesions. We are trying to divide the uterine vessels now on the right side now. So now after the division of uterine vessels, now we are going to the transcervical ligament on the right side, and then unipolar to divide the vagina from the cervix on the right side. So this completes the hysterectomy part of it. Still we have to tackle the adnexa of the right side. So before dividing the adnexa, once again we are trying to confirm the site of the ureter, which was seen well away from the surgical field. So nearly 2 cm space is available. Now we are trying to remove the adnexa. That is a tubo mass of the right side. So now almost completely excision of the adnexa of the right side is being performed. So that is the tinea coli adhesion to the adnexa. So now this is the completion of hysterectomy and left salpingophorectomy and a right side salpingectomy with right ovariotomy. So now we are approximating the vault using number 1 vicryl with attachment of the uterosacral ligament to the vault of the future vault of the vagina. We can see how much friable the tissue is due to the inflammation. So this is a case of total laparoscopic hysterectomy that was performed for a patient with a repeated episodes of pelvic inflammatory disease, and then the patient had landed in a tubo-ovarian mass, so which was not relieving her symptoms by repeatedly taking antibiotics for her, and which was having a debilitating dysmenorrhea and menorrhagia for her. So we performed a laparoscopic hysterectomy. So care should be taken that whenever there is a adnexal mass, then every time try to identify the ureter, and if the ureter is exposed, only then tackle the infundibulopelvic ligament. If you are still finding difficult to excise the adnexa from in toto with the uterus, then very well divide the cornual pedicles, and then you can finally, after completion of the hysterectomy, you can go back and remove the adnexa safely, where we will have enough exposure, and the dissection also becomes much more easier. So usually 4 knots are taken, and 2 stitches are taken on the right side, and the one on the right side and on the left side, including the uterosacral ligament on either side of the vault, to prevent the vault prolapse in future. So if there are any doubts about this video, please put it in the comment box. Try to answer. This completes the surgery, and later we just have to identify the safety of ureter as a completion procedure at the end of the surgery, and the bladder. So that is the right side ureter, which is usually identified by its peristalsis, and then so that is on the left side, so which is completely dissected and kept. So thanks for watching this video.